Hello and welcome to today's webinar, California Maternity Care and Reproductive Health Policy Updates, made possible by the California Healthcare Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, participant audio lines are muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A policy cheat sheet on the information covered in today's presentation, as well as the slide deck, will be made available for download in the Zoom chat box. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I'll now turn the webinar over to Preeti Kanal, Senior Program Officer at the Center for Healthcare Strategies.
Hello, everybody. Thank you so much for joining us today. My name is Preeti Kanal, and I'm a Senior Program Officer at the Center for Healthcare Strategies. And today I'm with my colleague, Senior Program Officer Diana Crumley. Diana and I will both be presenting in this hour. As Travis mentioned, this presentation is made possible through the support of the California Healthcare Foundation. A member from the California Department of Healthcare Services, CHCS, has reviewed this version of the presentation, but CHCS is responsible for any omissions or inaccuracies. We encourage you to please continue to look to DHCS for new policy announcements and additional guidance. Again, please feel free to send in your questions to the question box. Our colleague Anna Benya will be monitoring the question box for us today. As you may know, California is embarking on many policy initiatives that have the potential to impact maternity care in the state. And many of these initiatives have a specific focus on reducing maternal health disparities. Specifically today, our objective for this presentation is to explore how CalAIM and the 2021-2022, as well as the 2022-2023 state budget provisions enable more whole person care for pregnant and birthing people, with a specific focus on Medi-Cal and DHCS initiatives. So our presentation today is going to be set up in this framework. We're going to be using four dimensions to talk about our policy updates. So we'll talk to them in the context of who is covered, what's covered, how's it financed, and how's it delivered. And so the first set of policies that we talk about is under who's covered in terms of eligibility. We'll go into postpartum eligibility expansion, universal Medi-Cal coverage, and pre-release services for pregnant people. We'll start with postpartum coverage expansion. So California implemented this policy effective date this year, April 1st, 2022, and expanded coverage under Medi-Cal and the Medi-Cal Access Program. Previously, the benefit was extended to 60 days postpartum, and now it's being extended to 12 months postpartum. However, to be clear, California did have a postpartum coverage expansion, but it was only for people diagnosed with maternal mental health conditions under a program called Provisional Postpartum Care Extension. And now this benefit is being, the eligibility is expanded to 12 months postpartum, and it's regardless of mental health or immigration status. This is a big advancement that can overall improve maternal health outcomes in California because it includes the full breadth of medically necessary services through the pregnancy and postpartum period. And in particular, the change will expand access to services for undocumented residents, which was included in this year's budget provisions. Individuals who previously received limited Medi-Cal benefits through the 60-day postpartum period, and that is going to be expanded for them through 12 months. And to be clear, we heard a little bit of confusion, there is a little bit of confusion specifically. So just to reinforce this point here, all members with full scope Medi-Cal who become pregnant are already covered under full scope Medi-Cal and generally receive services through Medi-Cal managed care. This really applies to those individuals who didn't qualify for full scope Medi-Cal and get coverage on the basis of pregnancy now. And since California's expansion applies to undocumented residents, the eligible population becomes larger, and the folks who don't qualify for care, that population will shrink significantly. Next slide, please. We had an opportunity to speak to several stakeholders earlier this year on the postpartum coverage expansion. And one question that kept coming up for us was how does this postpartum expansion interact with Comprehensive Perinatal Services Program, CPSP? So for a little level setting for folks who are not in California, the CPSP program is funded by Title V Maternal and Child Health Block Grant and administered through the California Department of Public Health. And CPSP provides services to Medi-Cal enrolled pregnant and postpartum individuals. That eligibility was for provided services through 60 days. So the postpartum coverage expansion through 12 months will likely be applied, and individuals may receive Medi-Cal services that are similar to CPSP for that full duration of the year. And another question that's come up is how can maternity care providers and stakeholders adjust care to maximize health benefits and individual awareness of this eligibility expansion? So as you can imagine, it's not just about implementing this new coverage expansion, but really making sure that the follow-through happens, that patients are appropriately being linked to primary, specialized, and behavioral health care, and not just with a focus on that immediate 6-week or 60-day postpartum period. We want to make sure that patients are being linked to the appropriate care for the entire year. And so DHCS can really consider how to define benefits relating to Medi-Cal providers with these goals in mind for benefits like the doula benefit that's being implemented newly and the community health worker benefit, for example. Next slide, please. Okay, so we're going to move on to the universal Medi-Cal coverage. This is a new initiative under the 23 budget provisions. By 2024, California will aim to offer full scope Medi-Cal coverage to all income eligible residents, regardless of immigration status. The 23 budget provided full scope eligibility to adults aged 26 through 49. Again, regardless of immigration status. And this has a huge maternal health equity impact, right? Because more people, especially undocumented residents, will be able to receive care before and after their pregnancies. And we all know that poor outcomes in pregnancy aren't only impacted by conditions that arise during pregnancy. You must consider conditions even prior to pregnancy throughout the reproductive lifespan of a person. So being able to receive coverage before and after is a huge initiative that's likely going to impact maternal health outcomes in California. We designed this, just a brief explanation kind of to show you the evolution of how full scope Medi-Cal for California residents evolved for undocumented residents specifically. And so in August 2022, they had the restricted scope pregnancy-related Medi-Cal coverage only for those who were up to 213% of the federal poverty level. And that was the 60-day postpartum coverage or the 1 year with the mental health diagnosis. And then cut to this year, it became full scope Medi-Cal coverage for all income eligible pregnant individuals, regardless of immigration status, with the 1 year postpartum coverage. And now it's going to be full scope for all income eligible residents, regardless of immigration and pregnancy status, with that 2024 target date in mind. So that's how the policy kind of evolved into where it is now. Next slide, please. Thank you, Travis. And so the next one is pre-release services for pregnant people under eligibility expansion. So this policy is pending federal approval right now, but basically DHCS requested to provide targeted Medi-Cal services to eligible justice-involved populations 90 days pre-release. So it expands eligibility for Medi-Cal for those who are 0 to 213 federal poverty level, which is consistent with the other standards. And pregnant people in this population would be a priority to receive these benefits. And so what's the potential impact? The way that it was described in the CalAIM proposal, DHCS projects that approximately 200,000 individuals would have access to pre-release services, and with pregnant individuals being a portion of this population, of this total number. We were unable to locate statewide estimates of individuals who are pregnant and in jail or prison, but in LA County in a 2018 survey, about 5.2% of jailed individuals were pregnant and 35 individuals gave birth while incarcerated. So this is obviously a marginalized population, often gets overlooked. And so for this eligibility to expand to this population is another way to close health disparities in California when it comes to maternal health outcomes. Next slide, please. All right. We have to get through a lot of policies because there's a lot happening in California. So we're just going to move forward to the what's covered section of the presentation. And so here we're going to talk about the new doula services benefit, community health worker services benefit, Diatic behavioral health visits, required enhanced care management, and optional community supports. And you may have noticed that I skipped over midwifery services. So I just want to say a caveat there for midwifery services. To be clear, that was already a benefit in California. Midwifery services was already reimbursed benefit under Medi-Cal. But here for today's presentation, we specifically talk about the midwifery workforce expansion initiative, which was part of last year's budget. But midwifery service has already been reimbursed at 100% of the physician rate in California. So we'll focus on the workforce expansion bit. Next slide, please. Okay, so doula services is a big one. There's been a lot of diligent and collaborative work being done around implementing this benefit, submitting the SPA to the state plan amendment to CMS, and we'll talk about that. The target date for implementing the doula benefit is going to be January 2023. And just for a little bit of level setting here, I want to make sure that everybody knows that doulas provide emotional and physical support to individuals and families throughout a pregnancy, childbirth, and postpartum experience. And they can have significant impacts on advancing more equitable, culturally congruent, and can improve outcomes for communities of color. So the doula stakeholder work group worked with DHCS to create a state plan amendment. And I think the timeline is that they're going to be submitting that amendment very soon. There's a current version of it that was recently developed earlier this month on July 1st. And stakeholders and community participants have advocated for a careful approach to benefit development with a caution that rushed implementation could exacerbate racial inequalities. This is key. The original timeline was for January 2022, and then it got postponed to July 2022, and now it's January 2023. And we make that point because the collaboration and the continued engagement with doulas and the stakeholder community was just such a significant part of designing a benefit that really was equitable and could look toward long-term sustainability of the doula benefit in Medi-Cal with an eye for a sustainable workforce and support for that workforce. Next slide, please. So we explored several questions with doula stakeholders earlier this year as well. And just to be clear, because of where we are in this phase with the SPA, having gone through several iterations now, some of these questions I just want to say that have been answered in that process, in that conversation that DHCS and stakeholders have had. But there are going to be there are going to be several remaining questions that are going to be answered throughout the implementation phase of the doula benefit. But I want to highlight sort of the evolution of that conversation and what are some of the key implications and conversations that were had. So how can rates and reimbursement reflect the unique nature of doula work and support a living wage? Doulas often have fewer clients, right, than other maternity care providers like hospitals, midwives, and obstetricians. And so adjustments need to be made to reflect those lower caseloads. That was a question that came up substantially in this process. How can DHCS ensure that rate setting and reimbursement issues are considered as important and in tandem with benefit development and not in a siloed way? Reimbursement levels will be crucial to long-term sustainability and equity in implementation. Payment should be integral to long-term success of the doula benefit. Cost of living is a huge concern because, as you all know, states have varied cost of living, but California is an expensive one. So if we're going to integrate doulas into Medi-Cal reimbursement and Medi-Cal care, then it's important that we, the state and policymakers keep that in mind. What is a sustainable living wage and how can we support doulas in that process of integration as much as possible? And so also considering supporting independent providers and sole proprietors, right? Because doulas have been providing their services for decades in their communities and as independent business owners and receive payment outside of health insurance reimbursement. So inadequate payment may deter these providers from participating in Medi-Cal, right? What's the incentive if they're not going to be able to make that same amount that they did before? And that ultimately reduces access to culturally congruent support for people during pregnancy and the postpartum period. So interviewees really communicated the need to reimagine systems and support bold policies in partnership with communities. And I think that collaboration is an exemplary one for other states to learn from as well, about designing a system that works for both parties. Next slide, please. And a few other questions that we wanted to highlight about credentialing and scope of work and workforce expansion and sustainability. Some of these questions, again, have been answered in the design of the SPA, right, the state plan amendment. But again, there might be some key remaining questions. So I'm not going to go through all of these, but are these resources community defined and culturally appropriate? How can the benefit be developed to eliminate the need for supervision by a licensed practitioner? And you'll see as you get more familiar with the California SPA that some of these are addressed in there. And workforce expansion and sustainability questions, as I mentioned, will be continued to be answered, those questions in the implementation process, right? Like outreach to Black and Latinx communities, how can those be improved? How can state policies support mentorship programs for hands-on experience, TA, and mental health support for doulas? These are really important as we talk about the longevity of doula benefit in California Medi-Cal. Next slide, please. Okay, and then this is a slide that shares upshots from the spring stakeholder work group meetings and highlights from the state plan amendment, the version that I mentioned that was released earlier in July. You know, standard stuff that you would expect to be in a SPA, like the minimum qualifications, training pathways, things like that. But what I do want to highlight, especially as we talked about rate setting and reimbursement, is that through this collaborative process, in this year's budget, the 22-23 budget, the budget did approve a rate of $1,154. And this includes the total of an initial visit, 8 follow-up visits, and a labor and delivery visit for that doula package. And so a unique thing and the way that California chose to proceed, and was also a point that was important to stakeholders, was that this model allows flexibility. So doulas can be reimbursed for individual visits, so that one doula doesn't follow the one patient the entire time for all of these visits. There's flexibility in who you may see. And so doulas have the flexibility to have a portion of visits or like one visit, and they can be reimbursed for the individual encounter. Next slide, please. So I'm going to move on to community health worker services. And just to highlight here that the process for developing and designing the state plan amendment that was submitted on April of this year for the community health worker benefit was very similar to how the stakeholder process happened for the doula benefit. So so there's parallels in how the whole approach worked, and designing a benefit that really included community health worker stakeholders is an important point to make. For a little level setting, again, community health workers are trusted members of the community who help address chronic conditions, preventative care needs, and health-related social needs within their communities. And they can provide services to individuals during pregnancy and postpartum care, including to address perinatal health conditions and sexual and reproductive health. So that specific specificity was included in the budget provisions, that with the implementation of this benefit, that there's going to be a portion of the community health worker workforce that are also going to specifically address maternal health or perinatal health conditions as it's written. We offer additional resources on every slide, where if you need more information, you can go into look, and also have offered an email address for additional questions on the state plan amendment for the community health worker benefit. So when we had an opportunity to talk to stakeholders about this benefit in particular, a question that came up is, again, the interaction with CPSP. So how will community health worker benefit impact maternity care providers that offer comprehensive perinatal services, prenatal services program, sorry. CPSP services can include health education, health navigation, and community referrals, and can be provided by comprehensive perinatal health workers. So the role of the CHW is similar to what folks were doing under CPSP, and that benefit could support CPSP-like services beyond the 60-day postpartum period, right? Because that postpartum eligibility expansion is applied overall. So patients will get that care through the 12-month mark. And then the CHW benefit, could impact what is considered an encounter or alternative encounter under a QHCs and rural health center prospective payments and the future APM model, which we talk about a little bit more in detail later. Okay. And then as we laid out with the doula benefit, we did something similar here with the community health worker benefit, upshots from the version of the SPA that was submitted to CMS in April of this year. Again, minimum qualifications, training requirements, and things like that are all included in the SPA. But one bullet that I'd like to call out specifically is CHWs must have lived experience that aligns and provides a connection between the CHW and the community being served. So it goes with that whole person care priority that California is taking on with this multifaceted approach, that we really are serving the populations that are in need, and providers and folks who are involved in care management in different capacities all reflect that population and can connect and reduce barriers to those populations in need specifically. So that was a highlight of the design of this benefit as well. Next slide, please. All right, and then we'll move forward to midwifery services. And as I mentioned before, midwifery services was already a benefit covered under Medi-Cal. And for level setting, midwives are clinically trained professionals with expertise and skills in supporting women to maintain healthy pregnancies and have optimal births and recoveries during the postpartum period. So when the SB 65 bill was passed, it included a component for the prioritization of expanding access to midwifery programs in California. And so the Midwifery Workforce Training Act would connect the California Department of Healthcare Access and Information with training programs for certified nurse midwives and licensed midwives to increase the number of students receiving quality education and training. There's a limited number of training programs, and so this act prioritizes the need for expanding programs and making it accessible to more people. And also the priority is to focus on training designed for medically underserved, lower socioeconomic status and rural communities. You know, in maternal health, we know that there's a problem across the US about maternity care deserts and lack of access for folks in certain areas. And so to reach these hard to reach communities or communities that often face barriers, DHCS in California is trying to expand the workforce in order to address those specific needs. And what are the implications and opportunities in this, right? So some of the questions that came up, you can expand a workforce and you can be very successful in recruiting and training a workforce and creating that workforce. But if that workforce doesn't have a place to provide their services, there's going to be an access and utilization problem. So what are some of the things or policies that stakeholders can work on concurrently while that workforce expansion is happening? And so supporting implementation of freestanding birth centers is always a priority, especially in maternity care deserts that I mentioned. Questions about the reimbursement rate of midwives, could they be improved? How does that play a role in recruitment, retention, and sustainability in maternity care deserts? One stakeholder I recall mentioning that what happens is, like, large counties that have, you know, big reputations and names get a lot of funding, but there are still pockets within counties that might be overlooked, or that more barriers exist, that those connections are not happening and those services are not delivered in that area. So even though you don't think of California as having maternity care deserts, they still exist within certain counties and in certain populations. And the other thing is, do midwives have the support they need from hospitals and OBGYN providers? Again, you can have a workforce of, you know, fully equipped, ready to work midwives, but if there's not an overall support for that service and that role, it's going to create more barriers to access and utilization. For example, physician oversight has been formally removed by California, but some health plans still enforce it. So addressing some of these issues in tandem with the workforce expansion will be really important for stakeholders to achieve the optimal maternal health outcomes and goals in California. And then the last one for me, at this point, we're going to talk about Diatic behavioral health visits. We wanted to highlight this and especially its maternity care impact. So Diatic behavioral health visits These services are provided to the child and caregiver or parent at medical visits and can include screening for health-related social needs, such as food and housing insecurity. So we go back to that point and that goal of California's initiatives really targeting that whole person care approach for pregnant and birthing people. And so this is another way to capture that population and make sure that pregnant and postpartum patients are screened during these well-child visits and connected to the services they need. So it's another way to address that and impact maternal health outcomes. And we highlight just a potential payment model. So we talked to some folks who did a pilot on this Diatic behavioral health visit, and it was called Babies Don't Go to the Doctors by Themselves, led by California Children's Trust, UCSF, and 0 to 3, and one model to consider as we implement the Diatic behavioral health visits benefit. And then now I'm going to turn it over. You can go to the next slide, please, Travis. Now I'm going to turn it over to my colleague, Diana, who's going to go to the next section of the presentation.
Thank you, Preeti. So the next two initiatives I'm going to discuss relate to CalAIM. And essentially, CalAIM is a long-term commitment to transform and strengthen Medi-Cal to make it more equitable, coordinated, and person-centered. So very much related to the general themes that we're discussing today. So one component of CalAIM is enhanced care management. Enhanced care management is required for Medicaid managed care plans to provide, and it is intended to be very much a partnership with network providers and CBOs. So perhaps if you are working for a primary care provider, a community health center, a county behavioral health agency, a community-based organization that specializes in particular populations, you may have already heard about enhanced care management. So just to be clear, enhanced care management is not necessarily specific to pregnant people, but there's something called populations of focus. And essentially, there are a number of adult populations of focus as well as youth populations of focus. And pregnant and postpartum people may fall under, for example, adults with serious mental illness, individuals transitioning from incarceration, and individuals and families experiencing homelessness. So ECM is rolling out in different counties at different times. So you can go on the website and see where it might potentially be available and what potential partnerships you can build with your local managed care plans. Next slide. Another CalAIM initiative is the Community Supports Initiative, and that's essentially a list of 14 pre-approved services that generally address health-related social needs. They're intended to be preventative, medically appropriate, and cost-effective substitutes. And a specific example here that's very much relevant to pregnant people is the medically tailored meals and medically supportive food for people with gestational diabetes or other high-risk perinatal conditions. But you can also find things like housing navigation services for people experiencing homelessness. So some questions that you might want to ask is, first of all, does my patient's managed care plan offer that service for enrollees in the county? There's a big matrix where you can line up a plan with your county and see what is being provided. The second question is, does the patient meet eligibility criteria for the services? And DHCS has created essentially a standard eligibility criteria, but plans can potentially add to that with some prior authorization requirements and some other controls. Next slide. So the next piece of this beautiful pie is how's it delivered? And you will see that most of these categories relate to managed care in some capacity, either who's enrolled in managed care or perhaps the specific responsibilities and accountability mechanisms for Medi-Cal managed care plans. Next slide. So first, there will be mandatory managed care enrollment for a particular population, 138 to 213% of federal poverty level. Previously, this population was essentially receiving fee-for-service Medi-Cal services. And so one change is essentially this group will be enrolled in a Medi-Cal managed care plan and be able to access more coordinated care, both postpartum and after the postpartum period. Next slide. So something that was passed in the 2021-2022 budget was an equity dashboard and an annual healthcare service plan health equity and quality review. This is actually not a DHCS specific initiative, but nonetheless is affecting Medi-Cal managed care plans. And you can go online and see essentially some of the suggested measures that are under review. Some of them are under the birthing persons category, as well as a health equity related category. And these will essentially influence the industry as a whole, but it will also influence DHCS and its strategies moving forward. Next slide. And on that subject, there will essentially be more accountability for maternal health equity in Medi-Cal managed care. And there are two, perhaps three big documents here that describe some of that strategy, that planning, the goal setting that will be important for this work. First of all, in the comprehensive quality strategy, maternity outcomes and birth equity is one of three clinical focus areas, so very much a priority of DHCS. And there are also two 50 by 25 bold goals, and that's 50% by 2025, relating to maternity care. And essentially, it's setting a goal to close maternity care disparity for Black and Native American persons by 50%, and then to increase or improve maternal depression screening by 50% as well. Basically, fresh off the presses, in July, there's also a final population health management strategy and roadmap. And within that larger document, there is a reference to health disparity reduction efforts, especially for Black birthing persons, and a teaser for future guidance regarding best practices for maternal health outcomes. And to step back and give you a picture of what's going on in the state of California, earlier on this year, DHCS published its first statewide request for proposals for Medi-Cal managed care, with those proposals due in April 2022. And essentially, those contracts will become live in 2024. And as with most big managed care procurements, this was really an opportunity for the state to name some bold goals, to really set some quality goals and create new initiatives for managed care organizations to take on. So some of the things that you might see are to develop quality improvement initiatives with a health equity focus, to think about using community health workers and doulas, as we discussed earlier, and to reinvest a portion of profits in local communities. Next slide. So I noted that population health management strategy and roadmap, and essentially that roadmap describes two buckets: the population health management program and the population health management service. So the population health management program essentially states what Medicaid managed care plans should do to provide basic health management, to create a population needs assessment, to create a population health management strategy, think about risk stratification using data to really optimize services and really provide whole person comprehensive care and really focus on that preventive care. So here you see the general categories for basic population health management. Again, that focus on primary care, that focus on making sure that there's care coordination and navigation, and also referral to services that address health-related social needs, including community supports and wellness and prevention programs. And again, that reference to programs to address maternal health outcomes. And I noted, risk stratification and thinking about, ways that certain high-risk pregnancies may be prioritized for that care management based on some of that risk stratification and that thoughtful data analysis. Next slide. So the Population Health Management Program will be supported by a new tool called the Population Health Management Service. And that essentially brings data from a bunch of different resources and puts them together. So thinking about administrative and clinical data from physical health systems, behavioral health systems, what programs are being accessed by that particular individual. So this will potentially help, for example, identify gaps in enrollee referrals. For example, the Population Health Management Roadmap refers to earlier identification or earlier enrollment during a pregnancy into WIC. All right, next slide. And then another piece of our pie here, how's it financed? And here I am basically talking about different things that are affecting the payment landscape. So real quickly, there was a 10% Medi-Cal rate increase for alternative birthing centers, and you can definitely review related language in the new budget. And something that I am particularly excited about, given my interest in primary care and maternity care, there will be equity and practice transformation provider payments. And that essentially will help jumpstart and invest in care transformation to advance equity and improve quality measures. There are a number of potential categories, but maternity and preventive care is one of the categories listed in the brief description. And there will also be grants and technical assistance to allow small physician practices to upgrade their clinical infrastructure and advance adoption of VBP models. Next slide. Another thing that you might be hearing about is PATH. And PATH essentially connects back to ECM, that enhanced care management benefit, and community supports. And so there are a bunch of different types of funding and support that is being anticipated. You may be interested in the Capacity and Infrastructure Transition Expansion and Development Initiative, the CITED initiative. That actually will be direct funding for CBOs and providers that provide ECM and community supports. There's also a technical assistance initiative where essentially the state will set up a TA marketplace. And also a number of collaborative planning and implementation groups where essentially stakeholders will come together and identify gaps in community resources to really improve that vision for whole person care. Next slide. And next is the incentive payment program. And essentially that by contrast to CITED, which is directly to providers, the incentive payment program is specifically for managed care plans. But essentially what it's doing, it's pushing managed care plans to think strategically about capacity building activities. So thinking about building that provider capacity, building capacity among CBOs to really take up community supports and enhance care management and really push this program along. Next slide. And of course, FQHCs are important providers of prenatal and postpartum care. And this APM model for FQHCs may impact and add additional flexibilities for that care. So essentially, and this is brand new, approved under the most recent budget, managed care plans would pay participating FQHCs a per member per month rate for all assigned Medi-Cal patients instead of an end-of-year supplemental payment. General goals are to deliver care in the most appropriate patient-centered manner and think about more flexibility to provide group visits and email consultations, which are very much important components of prenatal and postpartum care. We don't have a tremendous amount of details yet, but there are plans to submit a SPA to CMS in 2022. All right, and then I will turn it back to Preeti.
Thank you, Diana. So the next section is on protecting access to abortion and strengthening reproductive health providers. As you can imagine, this is a response that California has been very proactive in terms of responding to the federal Dobbs, the SCOTUS ruling in the Dobbs case and the overturn of Roe v. Wade. And so California is embarking on a set of initiatives to address that particularly. And so we'll talk about the 23 budget, abortion care services in Medi-Cal, reproductive health initiatives outside of Medi-Cal, as well as a multi-state commitment to reproductive freedom. So in this past budget, this is very new. Equity and infrastructure payments for clinic abortion providers is part of the new budget. So $30 million of the general fund over 2 years will be allocated for DHCS to provide supplemental payments to non-hospital community clinics that offer abortion care services to Medi-Cal beneficiaries. So to support potentially influx of folks accessing abortion, to preserve access for folks in California already, this new funding will go toward supporting communities and community clinics. A modification to the Medi-Cal telehealth billing requirements to remove requirements for in-person follow-up visits and ultrasounds when not clinically indicated. This essentially reduces a barrier and an undue burden for folks who might be traveling and can go through an easier process to get the care they need and complete the care that they need. And a clarifying point here, so does Medi-Cal cover abortion care services? Yes, it does in California, and it has. California's Medi-Cal program covers abortion for any reason using state-only funds. Some of you may know that as the Hyde Amendment prohibits federal funding from being used toward abortion, with the exception of circumstances of rape, incest, and if the patient's life is in danger. But 16 states, including California, use their own state funds to increase access to abortion services beyond these scenarios. And then initiatives outside of Medi-Cal for reproductive health, some examples that we included: uncompensated care funding for reproductive health services. So $40 million, again, a one-time general fund allocation is available for 6 years for the Department of Healthcare Access and Information toward grants to reproductive healthcare providers to offset the cost of providing care to underinsured and uninsured individuals who do not have healthcare coverage for abortion care services. So folks are going to be coming from out of state who don't have California, healthcare benefits. Of course, it's going to look to offset some of that that new burden that California might be encountering in the coming years as a result of this decision. California Reproductive Justice and Freedom Fund, $15 million for the California Department of Public Health to award grants to community-based reproductive health rights and justice organizations to conduct medically accurate and culturally competent outreach and education on sexual health and reproductive health issues. So just an all-encompassing approach that includes family planning and education around reproductive health in general. And you can look for a full summary in this link that's provided here. And then lastly, California is also linking up with states, near states, Oregon and Washington State. And on June 24th of this year, the governor signed an agreement with specific commitments, and that was to defend and protect licensed medical professionals in continuing to provide reproductive health care. And then promote greater access to abortion care services, including by expanding access to medication abortion, removing barriers to telehealth for reproductive health care services, as we highlighted before, and then also growing the pool of qualified practitioners who may provide abortion and other reproductive health care services. I think now California actually does allow nurse practitioners to provide abortion services. And so looking into expanding that, or maybe potentially including other providers in that list who can provide abortions is another initiative that they will pursue. So that concludes our presentation today, and we are going to switch gears to the question and answer portion. I know that there are some good questions that are coming through the chat box. And just give us 1 second. We're gonna, let's see.
There was a question about avoiding duplicate or triplicate billing for the same services across programs. I think that is definitely a focus of DHCS, future DHCS guidance, and stay tuned on that front. But certainly when it comes up, there's often like a reminder that like these services shouldn't duplicate other services, and to be mindful about that overlap. And Preeti, I was wondering if you wanted to sort of zoom out of California and give a little bit of a meditation on how these trends are very much resonating across states, and then also nationally or federally with CMS.
Yeah, so some of you there was actually an announcement yesterday from CMS that, let me just 1 second here. So CMS released Maternity Care Action Plan to implement the Biden-Harris Maternal Health Blueprint, and you'll see a lot of overlap with what CMS and the federal administration is endorsing and providing support for CMS for states to pursue with CMS support, and a lot of overlap between what California is doing and other states are embarking on as well. I would also highlight that implementing the doula benefit is something that many states are doing right now, and they're in different phases of that work. So California, while they're just submitting the SPA, a lot of other states are further along in the process. And today's presentation highlights the policy design and the beginning of policy implementation. There's a lot to be learned in terms of implementation challenges and successes with new benefits that have already been enacted, and folks are starting to begin the reimbursement process for doula services. And so I would just highlight that that there are learnings there too. And a lot of those challenges come up on the workforce expansion piece and creating a sustainable workforce. I might highlight that as a national organization, CHCS has been listening to states working on the doula benefit implementation specifically. And one of the leading issues that comes up is around the workforce piece. Black and other BIPOC people have been leading the effort and are instrumental in bringing on the workforce needed for the Medicaid space. And there's a strong grassroots effort to make sure that workforce is well positioned to help people in Medicaid. And so doulas that are very dedicated to work, have deep ties with communities, are being assisted by organizations to provide the technical support and go through the process of integration into Medicaid. And there are a lot of learnings there. I don't know what else I might add. Are there other questions, Diana, because I know a lot of these questions are directed toward DHCS, and we're kind of interpreting on behalf of them. So we're not quite positioned to answer some of the technical questions on what DHCS might do. But Diana, do you see anything that we might speak to?
Yeah, there was one question about women that have emergency medical. Will they be transitioned from fee-for-service to managed care? And I believe that managed care implementation, or carving that population to managed care, that was specific to those who are lawfully present or citizens. So I think undocumented residents will still continue to receive services through fee-for-service, but they'll have a full scope Medi-Cal coverage as opposed to that more restricted scope. And hopefully that answers that particular question.
Mm-hmm. And I really like the focus on some of the questions we received are on some of the potential implications and implementation challenges that are to come. And I think these are really good questions for us to continue in this work, to make sure that stakeholders are aware of like what points of intervention and what implications and implementation challenges they can address. Like the CPSP, how will it be utilized? How does CPSP fit into this? These are still questions that are gonna need to be answered and worked through as these policies are implemented.
And I see an interesting question about, essentially reflecting on that maternal depression screening as a 50 by 25 goal. And potential resources on building out the mental health care workforce that focuses in on perinatal mental health. That's a potential use of those equity and practice transformation payments. And, of course, those gaps are yet to be filled, but that could be an important source of funding for practices that are interested in doing some behavioral health integration efforts specific to, maternal health initiative. So that might be one source. And certainly outside of DHCS, there are a whole bunch of other healthcare access and information initiatives focused on workforce that might be relevant, and essentially, other pots of funding that talk about behavioral health quality improvement, strengthening home and community-based services. So definitely in this wider landscape of a really increased focus on that whole person care. And also, just thinking about what is needed in order to make this work happen.
And for the question that someone asked for folks who gave birth before the expansion, are they still eligible for the 12 months of full scope Medi-Cal? I believe the answer to that is yes. As long as the aid code that's used is tied with the pregnancy, and they're in the postpartum period, then they should be eligible to receive that benefit to the 12-month period.
And there was a question about rural communities and access to these providers, and that can be a relatively broad question, but I think rural health is something that comes up in many different states, and California included. And so there are many ways that you can address this problem. Preeti, maybe you can talk about some of the maternity care deserts themes that you discussed earlier on in the slide. And then maybe I can, talk about what's being discussed or explored in the context of ECM and community supports, which perhaps that's two ways of addressing that particular question.
Mm-hmm. And thank you, Diana. There's a related question here earlier from Lynn Kersey, who asked, who made a statement about plans are only required to have one midwife and one alternative birth center per plan service area. But at the same time, access is guaranteed for individual pregnant people if someone wants a midwife or an alternative birth center. And so these are two contradictory policies that need to be addressed as well, which is a really good point, that it speaks to the access and utilization piece. Like if we expand the workforce, then that might be one way to start addressing this problem, having more available providers, and then potentially, making changes to the policy from there when that availability expands. But then being able to meet that capacity and going into these desert communities, investing in them more, and enabling also providing support and enabling the opening of freestanding birth centers, making regulations and the stand-up process for freestanding birth centers more easy, making accreditation processes more easy and facilitated, will also be steps that need to be taken in tandem with that workforce expansion piece.
And, in terms of rural health and ECM and community supports, DHCS recently put out some webinars about rural health, access to these services in rural areas. And so it certainly is a challenge, but something to be worked upon and enhanced potentially with the PATH funding through the incentive payment program, really thinking about ways that you can build up this capability in rural areas, and what potentially does that look like, and how can those services really be closely connected to the community and make them more culturally appropriate and really promote health equity. I think we have a question about CPSP. Do you want to take that, Preeti, and then kind of describe the question there?
The CPSP is a mandated benefit one, Diana, from Holly Smith.
Yes, exactly, yeah.
CPSP is a mandated statutorily mandated program from Medi-Cal. It looks like almost all pregnant people will be in Medi-Cal managed care in the near future, and their wraparound services will be provided by the managed care plan. And there will be expectations for this as part of the population health management strategy by DHCS. So that said, how will CPSP fit into this? Will it still be utilized? Will it still be billable by providers? And will managed care reimburse for the CPSP billing codes? I don't know if I'm well equipped to answer this specific question. As we see it right now, CPSP benefits will still continue to be utilized and interact with some of the other benefits that are being implemented, for example, the postpartum coverage expansion to 12 months. So, CPSP was providing servicing pregnant and postpartum people up to 60 days, and they're going to continue that. They're likely going to be continuing that benefit through the 12-month period. In terms of the utilization and that implementation and billing, we did not see specifics on that. So that might be a good question for stakeholders in California to be involved with, like what that interaction actually looks like in the day-to-day and in practice.
And I think CPSP will continue to be a very important program. I know that it's important to FQHCs, but to the extent that CPSP ends after 60 days postpartum, there will still be flexibility, for example, under the community health worker benefit to potentially continue CPSP-like services after that 60-day period. So I think it will continue to be important. It's referenced in that population health management strategy and roadmap, but continue to look out for additional DHCS guidance and support on that. And we can definitely take these questions and send them to DHCS through the California Healthcare Foundation. Again, we're not here on behalf of DHCS, and so don't want to speak out of turn, but certainly they can take these questions back and perhaps think about strategic guidance that they can provide in response to these very specific concerns. So thank you so much for these questions. And I am seeing another question about CPSP and CalAIM and ECM. I think we want all these programs to be complementary, and I think that's something that you can work out with that ECM contract with managed care plans, thinking about how ECM can complement CPSP and perhaps enhance CPSP services. ECM, again, is specific to particular populations of focus, so those with very complex health and social needs. So there certainly will be fewer people eligible for ECM and many more people eligible for CPSP.
And I know we only have 1 minute left here, but I do want to address the Perry Lambert's question. In rural health settings too, but in all communities, people are generally unaware of midwifery services available through Medi-Cal. What can be done to increase visibility of midwives? That's a great question. And in the Workforce Expansion Training Act and the plan sort of under it, as we know of right now, one of the priorities is to recruit midwives that reflect the population, reflect these specific populations that are underserved. And so developing a workforce that is representative of that population, being able to connect, specific individual with profiles to connect to these communities will be a priority too. So I'm hoping that that's a part of the implementation of that workforce expansion, that to create that visibility as the workforce becomes more representative of those specific populations.
Well, thank you so much. And in the chat, we dropped a link to essentially a collection of resources, a sort of cheat sheet that's shorter, an in-depth analysis, and that essentially looks like the slides that we presented today. And so look forward to reading your questions and sharing that with DHCS and the California Healthcare Foundation in the future.
Thank you so much for joining us all.